Let's talk about ocular medications. If you work with patients who have eye problems, you'll be using these a lot, and it's not enough to just know the names. You have to understand how they work, how the eye absorbs them, and how to give them in a way that makes them most effective. The main goal is straightforward. We want the right amount of medication to get to the right part of the eye, in a high enough concentration to do its job. But the eye has natural defenses that make this trickier than you might think. The conjunctival sac, for example, is small. It can hold about 50 microliters, and each commercial eye drop is about half that size. Anything extra is wasted. The cornea has several layers: epithelium, stroma, and endothelium, and each acts as a barrier. There are also blood ocular barriers that protect the eye from foreign substances, but they also make it hard to get medications into the deeper tissues. Then there's the normal reaction of the eye itself: tearing, blinking, and drainage, all of which can dilute or wash away the drug before it has time to work. Where the medication ends up depends on the type of tissue and the chemical properties of the drug. Water-soluble medications pass through the cells of the corneal epithelium, while fat-soluble drugs move between them. Topical drops work well for the cornea and front structures of the eye, but rarely reach the retina in significant amounts. When we need medication in the vitreous or the back of the eye, injections are often necessary: subconjunctival injections for the anterior chamber, intravitreal injections for the posterior chamber. You'll encounter a few main types of delivery. Aqueous solutions are the most common. They're inexpensive, don't interfere much with vision, but they don't last long because tears dilute them quickly. Ointments stay in the eye longer and can achieve higher concentrations, but they blur vision, so they're better for treating the eyelids and margins. There are also special delivery methods like contact lenses or collagen shields soaked in medication for corneal infections. Even with all these options, topical drops and ointments remain the most widely used. They're non-invasive, can be self-administered, and tend to have fewer side effects. Most eye medications have preservatives to prevent contamination. Benzalkonium chloride is common. It even helps some drugs penetrate the cornea better, but some patients are allergic to it, and in those cases, we can get preservative-free drops from a compounding pharmacy. Now let's go over some of the major categories of ocular medications. Topical anesthetics like proparacaine or tetracaine are used before diagnostic procedures, such as tonometry, removing sutures, or taking corneal scrapings. They're also helpful when a patient has severe eye pain and needs to open the eye for treatment. They work fast, usually within 20 seconds to a minute, and wear off in about 10 to 20 minutes. While the eye is numb, patients must be told not to rub it. They can injure the cornea without realizing it. Mydriatics and cycloplegics are another category. Mydriatics dilate the pupil by relaxing the ciliary muscle, while cycloplegics paralyze the iris sphincter, so the dilation lasts longer. We use them together for surgeries and fundus exams. Patients need to know they'll have glare and trouble focusing on near objects for a while afterward. Sunglasses help, and some can drive safely after the appointment, but others will need someone to take them home. These drugs can affect the central nervous system, especially in the very young and the elderly, causing symptoms like confusion, ataxia, or even hallucinations. They're not safe for people with narrow angles or shallow anterior chambers, and they interact with certain antidepressants and MAOIs. The effects last anywhere from a few hours to over a week, depending on the drug. Atropine, for example, can keep the pupil dilated for up to 10 days, while phenylephrine wears off in just a few hours. Glaucoma medications are used long-term to lower intraocular pressure by either decreasing the production of aqueous humor or increasing its outflow. Treatment is lifelong, so patients must understand both the eye-related and whole-body side effects and be committed to staying on therapy. Anti-infective medications include antibiotics like penicillin, cephalosporins, aminoglycosides, and fluoroquinolones. Antifungals like amphotericin B, which is powerful but can cause serious side effects like conjunctival necrosis and retinal toxicity, and antivirals such as acyclovir and ganciclovir for herpes virus or CMV infections. These carry the same potential side effects as when given by mouth or injection. Corticosteroids are often used to treat inflammation in the eyelids, conjunctiva, cornea, anterior chamber, lens, and uvea. They're less effective for diseases of the retina or optic nerve when given as drops, so those usually require oral or injected steroids. If it's a suspension, the patient should shake it before use. Long-term use can raise eye pressure, cause cataracts, increase infection risk, and slow wound healing. NSAIDs are sometimes used instead to avoid these side effects, especially after surgery. Anti-allergy medications help control allergic conjunctivitis and other hypersensitivity reactions, which are often triggered by airborne allergens or transferred from the hands. Severe cases may still require corticosteroids. Ocular irrigants are used to clean the lids, restore normal pH after a chemical burn, remove debris, or keep the eye moist during surgery. They're safe for the corneal surface as long as it's intact. Normal saline is often used after chemical burns. Lubricants like artificial tears are for dry eye or corneal irritation and can be given as drops, ointments, or inserts. From a nursing perspective, our goals in giving ocular medications are to get the best therapeutic effect and to keep the patient safe by preventing both local and systemic side effects. One of the most important techniques is punctal occlusion, pressing on the tear duct after giving drops, to keep the drug from draining into the nose and being absorbed into the bloodstream. This is especially important for patients at high risk of overdose, like older adults, pregnant women, or those with heart, lung, liver, or kidney problems. We also need to allow at least 5 minutes between different kinds of eye drops, so each has time to be absorbed. Before instilling drops, warn the patient that a little stinging, burning, or blurred vision is normal and temporary. Always wash your hands before and after, and make sure the dropper tip never touches the eye. Put the cap back on right away. If the patient can't tell whether a drop has gone in, keeping the bottle in the refrigerator can make the drop easier to feel. And always have the patient or caregiver demonstrate how they'll give the medication at home, including punctal occlusion. Giving eye drops is more than just squeezing a bottle. The anatomy of the eye, the type of drug, and the way you give it all determine how well it works and how safe it is. Your role is to make every drop count.